Hi, everyone. Thanks for joining. And feel free to interrupt me at any point during the presentation to ask any questions. Like Mike said, I'll be speaking about my experience with the Sniper balloon occlusion microcatheter for liver embolization. Um, so why balloon TACE? Why do we need to use a balloon occlusion during chemoembolization? Well, number one, I think there's data to support its use. And number two, I think it makes sense when you delve into, how we do TACE or, what's the mechanism of action during conventional TACE. So as you know, in CTACE, we use a mixture of Lipiodol and a chemotherapeutic agent, and we deliver that directly into the hepatic artery. And when it gets into the artery, it eventually gets to the arterial level, and then through the peribiliary plexus, and eventually to the portal venule side. So what we're trying to do is really choke the tumor from both the arterial and the portal venule end, so that we can maximize tumor kill. And by getting to the biliary plexus and the portal venule side of things, we can really cause peritumoral infarction, as well as necrosis of the microsatellites. And so, the whole idea is to really achieve a kind of a curative TACE. And to do so, we really need to have maximum delivery of embolic into the tumoral bed. And so we know that, Lipiodol retention can be a useful imaging marker after TACE in terms of looking at treatment response and survival. So there are papers showing this, and when you look at the necrosis rate for tumor after TACE, it really correlates well with the post-procedural CT. The more dense, and this is not the greatest diagram here, but you can see the top line is when you have really compact Lipiodolization, and this is the bottom line with less dense Lipiodol retention. You get different survivals, and you get much better survival after a dense Lipiodol uptake into the tumor. And some of this, is explained by tumor biology because, as well-differentiated tumors are more hypervascular. They take up more Lipiodol, and so naturally, they do respond better. But besides tumor biology, I think whenever you see very dense Lipiodol retention in tumor, it often correlates with better tumor kill as well as better survival for the patient. And this is where a balloon occlusion TACE comes in. With balloon occlusion TACE, I believe that we can achieve a higher amount of embolic material to be infused into the tumor and into the peritumoral areas. So this is one of the first cases I did with Sniper. And as you can see on this image on the left, the cone beam CT performed immediately after BTACE. You have very dense Lipiodol retention within the tumor, as well as uptake surrounding the tumor. And this led to a really nice response. 3 months after BTACE, the AFP tumor marker decreased dramatically from over 5,000 to 7. And then the 6-month post MRI showed no residual disease. And eventually the patient underwent orthotopic liver transplantation, and the explant pathology showed 100% tumor necrosis. And 2 years after liver transplant, the patient's still doing clinically well without any evidence of disease. So I think with this case, it really helped me to solidify my belief that BTACE may help patients by really maximizing therapeutic delivery. And so since that case, we've done a bunch of cases with BTACE using Sniper. And this is our single center retrospective experience at Cornell. I published this with Dr. David Madoff, who was a former chief here at Cornell, now is a chief at Yale. And we looked at 31 patients that we treated with balloon occlusion TACE using Sniper for HCC. Among them, 15 patients we treated segmentally. And you can see the complete response rate was quite good. It was 73%. And the rest of the patients had partial response or stable response. The median size of the tumor in this series was 2.5 centimeters, but they range from 1.0 to 6.9%. The fluoroscopic image here shows that we really got nice delivery of hemoembolic into the tumor bed, and the post TACE CT imaging shows very, very dense accumulation of pliotol within the target tumor. This is a study out of Mount Sinai looking at balloon-occluded TACE, 26 patients, 60% complete response. And you can see here in the digital subtraction angiography image that the balloon really increases enhancement of the tumor and the surrounding the peritumoral areas.
Have you seen Dr. Lee, what Dr. Lee looks like?
Yeah. Can you?
Steve
Hello?
Lee?
Did somebody have a question? Hello? Okay. So yeah, this is these are other additional papers out of Europe and Asia. You can see that in all of these studies, when you compare TACE performed with balloon occlusion versus just standard microcatheter, you get improved complete response. The biggest, there's 5 case studies here, or case series here, but the biggest study is out of Europe. And you can see this one had 530 patients, and the complete response rate was similar to the Mount Sinai study of 59%, whereas the standard TACE had a complete response of 41%. So I think the data here speaks for itself. Although none of these were actually randomized controlled prospective studies, you can see that you get a nice response, from balloon occlusion TACE. Here again, these are the references to the studies that we just saw. This is the main study that has the most number of patients, over 500. It was a retrospective, but it was a well-controlled in terms of they used a propensity score matched analysis and showed that there was improved response with BTACE. So how does balloon embolization work? So without a without a balloon catheter, in a standard catheter situation, you have the catheter here, and you can see that the supplying artery has a blood pressure, or a pressure similar to what the systolic blood pressure would be, so about 100 millimeters of mercury. And in the healthy liver, you have 60 millimeters of mercury. And in the tumoral bed, you have 25. So naturally, when you give embolic through this microcatheter, you will, the flow will carry the embolic agents into the tumor because of this pressure difference. When you put the balloon up, what happens is that there's actually, because of the balloon being up here, the pressure just distal to this microcatheter tip is decreased slightly. And it goes to maybe 50 or 40. And when that happens, you can get what we call reversal of flow, because this is 50 and the surrounding healthy liver, the non-target tissue, it's 60. There's actually a reversal of flow because of the pressure difference, and the flow can actually reverse. And this helps to minimize non-target damage to the surrounding liver and maximize delivery of the embolic agents to the tumor itself. However, if you get the microcatheter to extremely or very close to the tumor, you can achieve what we call a high pressure embolization. And with this, you can really force all the embolic agents directly into the tumor through the peribiliary plexus and into the portal venule side even. And so this is an example of a low pressure embolization technique. This is a study published by Dr. Madoff, my former chief. So he used balloon assistance to reduce the downstream vascular pressure to avoid non-target embolization during TACE from inferior phrenic artery. So this is a normal microcatheter, or the sniper without the balloon up, and you can see good flow into this diaphragmatic branch up here, as well as the other 2 branches of the inferior phrenic artery. When you put the balloon up, you see the balloon up here. Look at this diaphragmatic artery right here, the top one. You see how it wants to go there, but then it actually reverses flow. Let me play that again. So watch this top artery. It's actually going up, and then it actually never gets there, and it reverses flow. So this is an example of low pressure embolization where the tumor supplying arteries, this one and this one, is perfused, but the diaphragmatic artery going to the non-target diaphragm is spared. And you can actually see this on these fluoroscopic images when we're injecting the Lipiodol doxorubicin emulsion. You can see how this top branch, the flow is actually being reversed. You'll see it in the beginning of this loop. Let me play it again. See, it's going backward because the pressure differences caused by the balloon allow the flow to reverse. And all the embolic ends up going to the tumor. And so again, you know, we can use the balloon-assisted TACE in a segmentectomy style for treating metastatic disease in the liver. As you know, metastatic disease is not as vascular. And so these hypovascular mets, you really need to force the embolic agents into the area that these tumors live in. And one way to do this is really blasting that segment in basically a segmentectomy fashion using chemoembolic agents. And this is what was done for these mets here. So you can see that on this image, how densely the chemoembolic agents were delivered into this segment of the liver. And you can see how dense the Lipiodol staining is here, and a nice response after this balloon-assisted TACE. And then, you know, I've also been using Sniper for liver Y90. This is a case of metastatic pancreatic cancer. You can see that this is a right lobar treatment, and the cystic artery is lighting up. So I was able to get the balloon up just enough, or just distal enough, so that the cystic artery origin is blocked. And with that, you can completely avoid giving the Y90 microspheres into the cystic artery and deliver all of it to the target tissue. And here's another example for metastatic melanoma, Y90 here. You can see this is a Sniper balloon down. You can see the gallbladder lighting up here. And then with the balloon up, you can see that the gallbladder has disappeared. So, you know, you can either block the origin of non-target vessels, or, you know, with the low pressure embolization technique, you can reverse the flow in non-target areas if you can achieve that kind of pressure changes. And so in summary, balloon TACE appears to significantly improve complete response in the liver by maximizing embolic delivery into the target tumor. Sniper allows for low pressure embolization to redirect flow away from non-target vessels and toward the tumor feeding arteries. And like we saw, the Sniper may be used to occlude non-target vessels and also prevent reflux, such as in the cystic artery. And I've personally used Sniper for the treatment of liver disease using, you know, in Y90. And that's pretty much it. Anyone has questions, comments? If you want to see additional slides or see the slides again, let me know.